All ready to get back into pediatrics after that? The heavy material? Okay. So we're going to go ahead and talk about pediatric trauma right now. And this presentation piggybacks onto the last one. It overlaps quite a bit, so we'll be able to go through some of these slides a little bit faster. My clicker's not working. Cool. Okay, so pediatric trauma is the leading cause of death for kids over the age of 1. Before the age of 1, number 1 cause of death is congenital abnormalities, premature babies, that kind of stuff. But once they hit 1, we're talking about, unfortunately, trauma. And again, like we talked about in the last presentation, there's anatomical and physiological differences that just lead us to have different injuries and different, with different mechanisms in children. So we talked about that big head that they have. Again, they're like lawn darts. When they fall, they're head first almost every single time. We talked about all this. And when you're talking about the head, the number 1 thing we're most worried about is traumatic brain injury, which, you know, is fairly common in kids. There's a range of injuries that are kind of under the umbrella of concussion. And concussion can be anything from a little bit of a headache all the way up to memory loss and learning disabilities that kind of extend for long periods of time. This is not up and coming, but it's an area of injury that they're really starting to focus more time on and recognizing that we really need to be paying attention to those kids on the football field who are getting head injuries. Has everyone heard of second impact syndrome? Right? So it's the idea where if you have a head injury and you don't come out of play and you don't take time to let your brain heal and you have a second impact, even if it isn't significant, you could have sudden death. Your brain just can't handle the double impact. And so there's legislation that's been passed that every school, every sports group should be having these forms filled out with the family regarding concussion injury, return to play, and just recognizing the importance that if a kid sustains a head injury, they need to come out. They need to be removed until they're cleared. So outside the realm of concussion, we have actual bleeds. So an epidural bleed happens right here between the bone and the covering of the brain. It's usually arterial. These are the stories that we hear where the kid has a loss of consciousness and they wake up, they're totally fine, and then rapidly become ill again. This one, I feel like we don't see quite as frequently as subdural bleeds. So subdural bleeds, you can't see it, it's over on this side. See this blue line right here? That's the covering of the brain. Subdural bleeds happen right between the brain and the covering here. They tend to be venous. They tend to bleed slowly, and so again, you can have that delayed diagnosis. Especially when you start talking about having fontanelles in the brain being able to withstand a little bit increase in pressure. Now, when you're talking about brain injuries, remember I was telling you that the pediatric brain is very soft, it's very fragile, it doesn't take much. And this one little girl who, her mom brought her in, she was 8 months old. Mom said she fell off the bed, which is appropriate for her age, but she landed on some clothes. I thought she was fine. And over the last few hours, she's just been acting weird. So it started out fine, no loss of consciousness, and now she's acting weird. And sure enough, when we're in the triage room, the baby's kind of just staring at me, and she did this really quick kind of weird eye-rolly thing, like she was sleepy. But she wasn't sleepy because she was staring at me. I could tell. It was very, even to this point, a little bit difficult to describe. And right there, that kind of weird mentation that was happening made me think, okay, something's going on. Sure enough, we scanned her, she had a bleed. Roll off a bed, not very high, land on a pile of clothes, but somewhere along the way, bumped her head just the right angle, just the right force, she had a bleed. So symptoms of traumatic brain injuries can be anything from vomiting, a little bit of repetitive questioning, headaches, speech changes. This one boy who hit his head on a rock and he could not talk. He knew what he was trying to say, but he couldn't verbalize it. Didn't have a bleed, but he had a very significant concussion. When When kids fall, they usually hit their foreheads, right, because they're lawn darts. They get these big old Goombas on their head, big swelling, almost like a unicorn horn. Those are very common on the back of the head too. They tend to be firm. They're hematomas, they're giant bruises. And more often than not, it's just a bruise and it goes away and it's totally fine. Now, if you have a head injury with bogginess, that's indicative of a skull fracture. And what bogginess is, it's not firm swelling, it's more like waterbed. Like you can hit it and it kind of jiggles around. That can be indicative of a skull fracture underneath. The other thing that can kind of lead you to think they have a fracture going on is pain when you touch around the area. Now, if I have a big bruise on my forehead, of course it's going to hurt. But when you have a skull fracture underneath, they're very painful. It's not just a little bit of discomfort. So if you have a kiddo with a brain injury or a head injury, of course you're going to maintain their C-spine as best you can, if appropriate. Support their airways, support their cardiovascular function, get them to the hospital, and frequent reassessments to see if their mental status is changing. Now, hyperventilation. When you hyperventilate someone, you have all the CO2 changes, you have these chemical changes in the body. And when you talk about brain injuries, bleeds, herniation, hyperventilation is used as a last-ditch effort to change intracranial pressures to prevent herniation. Last ditch, meaning you have the triad, your blood pressure is changing, your heart rate's going down. But before that, when you just have a kid who maybe you've intubated because their GCS is, 7 or 6 or whatever you have, hyperventilation can do more harm than good. And we have to go back to that idea of how much blood supply the brain needs. Kids need double the blood flow to their brain. If we're hyperventilating them, we're constricting the blood vessels in the brain. We're taking away their blood supply. We're injuring their brains more than we are helping them. So when you have an intubated kiddo, you really got to pay attention to how fast you're breathing for them. Make sure you're not doing too much too fast. We talked about the spinal column. I wish you could see this. So this is a lumbar vertebrae that is completely shattered. On the back end, you can see it's a complete blowout. And what that is it's called a chance fracture. It happens with kids who are in motor vehicle accidents. They like to either take their shoulder harness, and put it behind their back or put it underneath their arm. They have rapid deceleration when they're in a motor vehicle accident. They bend forward and their vertebrae just burst. And they get pretty significant lower spinal injuries. Spinal injuries are actually very uncommon in kids. It takes a pretty significant force. If you're going to see them, you're usually going to see them in a car accident and or a sports injury. We talked about the chest wall and the idea that kids can lose a lot of blood, a lot of circulating volume into their chest. Has anyone had to needle a kiddo? Needle decompression on a kid? So kids need to be, let's see. I got to the slide in just a minute. We talked about stroke volume times heart rate and cardiac output. Again, paying attention to that heart rate. One of the most important things you can take away from my lecture. Because even in the hospital setting, tachycardia gets missed quite a bit. So when we talk about chest injuries, one of the most common things that we can see is either a tension or a hemopneumothorax. Kids can be needle decompressed just the same way as adults do. Hi guys, come on in.
These are doctors, paramedics, nurses, G's. Say hi. Yes, okay. Let's go right here.
What? Your teacher brought candy. Maybe I'm not going to give it to you anymore.
See, we got
So cute.
Your Mark's just doing this because you're here.
Oh, it kind of all went together perfectly, huh? I do, by the way, have candy for you guys, so if you want them, let me put it back here where you guys can reach it. I mean, usually I use it for bribing to make sure everyone stays awake. What's that? So, kids need to be needle decompressed just like adults do when they have injuries. The smaller the chest, the smaller the amount of air you're going to have in there. So I will tell you, in all the times I've had to do it, I've never heard that fantastic whooshing noise. It's never happened. But you should be able to see a dramatic increase in either your stats, your work of breathing. If your patient's verbal, they should be able to say, yes, I feel better. You may not choose to use that 14 or 16 gauge needle. You can use smaller, right? Smaller chests. And you don't have to go as far in. So just recognizing that because the chest wall is so much smaller, don't go as deep. The other thing that can be difficult, especially in a little kiddo that has no neck, you may not see tracheal deviation. There's no trachea to be seen because they have no neck. So you're really relying on your exams and your O2 stats and other such things. The other thing that's I've only seen it a couple times, but it does happen, is cardiac tamponade. You have an injury to the heart, and you have blood filling the pericardial sac. It washes the heart so much that it can't circulate blood. Not much you can do for that except for give them good BLS and get them to a hospital where we can drain the blood. So, and again, they're talking about one of the signs of this is distended neck veins, JVD. You're not going to see that on a little kid. They got these big bellies, they have no necks, so you're really paying attention to maybe you're in PEA, or maybe you don't hear any heart tones. When we talk about these kids having these really, really big bellies, they have very small pelvis. And so what happens is all their internal organs kind of stick out into this cute little tummy. I wish you could see the picture. They have really, really thin, weak abdominal muscles. I always envision, old school Barnum and Bailey, the guy who takes the cannonball to the stomach and he's really buff and he can handle it. Well, our kids are the complete opposite. They don't have abdominal muscles to protect their organs. In addition, their spleen, their kidney, their livers extend down past the rib cage, making them a prime target for injury. Their intestine has a bigger blood supply than ours do. So if we sustain the same injury, that little dude right there is at risk of losing more blood per his volume than I am, because he has more blood flow to that area. So that becomes really important again when you have a kid who maybe has seatbelt sign, has a perfed intestine. They will lose volume faster than we will. And so they need that volume replacement. Very common in kids to grunt when they have a significant belly injury. They'll want to pull their legs up. It relieves the pain, and they'll kind of breathe like that. And sometimes you want to think, okay, there's something wrong with the lungs. They will do that with a belly injury too. This is a ruptured spleen. That is a spleen that needs to come out, unfortunately. Now, when kids have lacerations to their liver, their spleen, their kidneys, they do really good. Their body is able to self-preserve and tamponade off. And so frequently, these kids will just need to be admitted, they get watched, and they can keep all their organs. Whereas in adults, they generally tend to take things out a little bit faster. Now, when you talk about these significant injuries, it doesn't take much of force. Debbie Tuggle, if you guys have met her through UT, has a sports injury lecture where she talks about recently. There was a young man who was playing basketball. He's high schoolish. Got an elbow to the flank. It was the right angle, just enough force that it actually shattered. I think it was his spleen. And by the time he was able to get up off the ground, get to the bench, he was diaphoretic, pale, and was essentially bleeding out. So it doesn't take that much force to have these injuries. All you need is the story and the symptoms to kind of put it together. They need an IV, they need rapid fluid replacement, and then they need to get to the hospital. So we, oh shoot, did I bring those? Here. Thank you for reminding me. Sorry, I move around a lot. So I'll pass these out to you guys, but then I need to hand these over to Travis and then on the trucks. These are the newest destination guidelines for pediatrics. Now, when I say new, not much has changed. The biggest change on here is if you look at GCS, children is now taking GCS for 13, whereas before we used to. Everything else has really stayed the same. Look at these. Things that are going to UT are the things that are really significant. So, we had a set of siblings that were in a car accident. They decided not to wear their seatbelts. In the back, they had a huge car accident. She was not restrained. There was significant intrusion. She was a UT patient. Now, she was properly restrained. She didn't have any injuries and looked well. She absolutely could come to us depending on her mechanism. So, yeah, that's a good way to think of it. Yeah. Now, the one thing that does get a little bit confusing on here is the burn situation. Where is that one? So smoke inhalation without significant burns comes to us, but then if you look over on the UT side, it says, where is it on there? Combination trauma with burns. So you have that whole kind of middle of the road. So what happens if it's a significant burn but there's no trauma? Where do you bring that one? Yeah, or some soup and they have a burn that kind of just extends on their trunk. That's something that we could absolutely take because there's no significant blunt force trauma. So there's kind of some decision making. It's up to you guys. You can always call in and get advice from the physicians to figure out if you're unsure where the best place is for those kiddos. And I will tell you, more often than not, because I review all the trauma transfers, you guys are doing pretty good about deciding where to take these kids. Every once in a while, there's one that maybe could have came to us and they could have avoided a second transfer, but one or two of those I think is pretty. And usually those tend to be like femur fractures can come to us if the mechanism isn't significant, like if they fell off their bike and they have femur fracture. If the high-speed car accident with significant intrusion with a femur fracture, that's a UT case because there could be multi-system trauma involved with that. So using these to kind of help you and then, again, calling in if you need assistance in making that decision. Does that answer your question a little bit? It's still kind of gray, still kind of up to your discussion on theme. So then we have musculoskeletal trauma, which tends to be, I think, one of the most common in kids. They break bones all the time. So again, they have the growth plates that we have to worry about when we're healing them, not so much on the front end. One of the most important things you can recognize is you can have significant blood loss with fractures, especially your big bones, so your femurs and your tibias. And if you have bilateral long bone fractures, even more so. So recognizing that these kids usually, they're associated with sports injuries, right? And when you're playing sports, you're already dehydrated a little bit just by the factor of what you're doing. Now you have some blood loss. They do need some fluid replacement. And pain management's a big one. Again, we talked about kids routinely being under-medicated for pain. So just recognize that broken bones hurt, and they need pain medicine. Fingertip amputations, again, a very, very common thing that we see with kids. They like to stick their fingers in, like, the jambs of the door, and then brother, sister, how many of you have yelled at the kid, quit playing with the door, right? Happens all the time. So when you do this, I ask that you put a moist dressing on the fingertip, not a dry one, because it sticks and it hurts when we got to take it off. So just get it a little bit wet. It'll help when they get to the hospital. Get the missing fingertip and put it in, again, a moist saline dressing on some ice if you can, and bring that to us. And then make sure they get some pain medicine, because these things hurt. They hurt really, really bad. I will tell you, most often than not, if depending on how big it is, like this, you probably won't be able to reattach that fingertip. The faster you can do it, the better. But we always ask you to bring it in just in case. I would say more often than not it gets disposed of. But if it's like an entire finger, you want to bring it in. I'm not 100% certain what the replacement time is on that. Sometimes they'll replace it even if they're not certain it's going to make it, just because it helps heal. It acts as a biodressing. Please don't. That's gross. Did you go on a run call where a dog had eaten a finger? So gross. Now if you have a finger that's been cut off like that, a clean cut, those you really want to bring in because those reattach very nicely, as opposed to a, yeah. She just blocked it from her memory. Like, I feel like I don't ever want to think about that again. Come here, dog. Oh, so gross. So outside of those differences, now we're going to talk about some common mechanisms for injuries in kids, and then the usual injuries that are associated with those. Most of our kids, especially here, their trauma has to do with blunt force injuries. Now, if you go to Chicago and some of the other really big areas, they have a very higher penetrating trauma than we do in our pediatric population. So, number one, blunt force trauma for kids is falls. Falls. Now, again, the lawn dart effect, they got these big heads, they fall, and they usually end up landing on their heads. You want to make sure that when you have a kiddo and you're putting them in spinal immobilization, you're using the correct size neck or using a wrong size can actually create more damage than good. So you'll have to properly fit those depending on which model you're using. Long bone fractures are very common, and then when you talk about falls, you have to take into consideration how high are they falling. So you have low, medium, and high heights. Your low heights are usually from walking distance, they trip, they fall, and usually what happens is they'll get an upper extremity fracture, like we call it a fooch, a fall on an outstretched hand. They'll fall out, they'll have a radius fracture, no biggie, we can fix that. Now, I'll tell you the only caveat to that is when they fall on something on their bellies. So if you have a kid who trips and falls on like a retaining wall or a toy, they can sustain pretty significant belly injury from that. But usually it's just on. Medium height, you start seeing more head-neck injuries because they have that time to invert. And then lower fractures too. For whatever reason, kids that are being carried by their parents, they trip and fall down the stairs, or they even just trip and fall from a standing position, sustain femur fractures a lot. Again, I don't know the physics of it, but yeah. And then high heights, you really start seeing more of the head, neck, and more multi-system. Now, take all this with a grain of salt, because I will tell you, if I see a kid who falls from a shopping cart next to a kid from a second-story fall, more often than not, the kid from the second-story fall is totally fine. They bounce, I don't know what happens, but usually they're okay minus some bumps and bruises. Second-story falls and falls off of dad's shoulders, for me, they have a bleed until I'm proven otherwise. It happens all the time. It's very common. On those kids, more often than not, we'll see some bleeding, some hemotympanum right behind the ear, which is indicative of a skull fracture and or a bleed. So, very interesting. Don't be misled by this information and think, oh, it was only this high. They're probably going to be fine. Now, with this, you have to take into consideration how big the kid is. A fall off this countertop for an infant is going to be very different than a fall off here for a school-age kid. So taking into consideration how big they are and how big the fall is. What's that? So NBCs, you can see here, these are 3 examples of how our kids, maybe he should watch this, this might be important for him. These are 3 examples of how kids wear their seatbelts incorrectly. And this is how they get hurt in car accidents. They don't wear their seatbelt the right way, or they take it off when mom's not looking. So right here you can see this one's up around his neck. If he gets in a car accident, he's going to have some airway issues there. Right here, it's underneath his arm, or I'm sorry, it's tucked behind his back. And then over here you can see it's tucked underneath his arm, and they usually do this to avoid this part. So all 3 of these result in pretty significant injuries. Namely, for these 2, we're talking about the chance fracture and the abdominal injuries. Anyone know what's wrong with these 2 pictures?
The chest.
Absolutely. This is way too low. It's going to result in belly injuries, and then she also has a risk of flying out the top here. What about this little guy? He's got too much padding. Yeah, absolutely. It's a little bit of both. No, it's like one of those onesies. It's like when the sleeping bag zipper ups.
That's actually that's a snowsuit.
It's a snowsuit.
That is an all-encompassing snowsuit.
Yeah.
The ones that make them look like a little starfish.
It's like the Christmas story. Yeah. So when you put your kiddos in car seats, you're supposed to strap them in and then put the blankets around them. Because again, with excessive force, this all compresses and then they can fly out the top. It just doesn't hold them in. And you're right, this is also too low. Probably because there's too much padding here and they can't slide it up any further. So, really important to, as you're out in the community educating people on correct seatbelt use, correct car seat use. Now, when you have a kid who's correctly restrained, you're in an MVC, usually what you'll see is facial injuries, scalp injuries, chest, abdomen injuries, depending on what kind of harness they were in. When they're improperly restrained, you can see all of those, plus you start getting spinal injuries, multi-system trauma, and a whole bunch of other really bad stuff. So there's this really cool video I haven't watched, but I've heard of. If you guys have a chance, it's called Room to Live. Has anyone heard of that? And apparently, again, Debbie Tuggle is teaching me all this kind of stuff. This lady gets into these car compartments of NBCs where people have died, and she shows them if they just had their seatbelt on and had been wearing it properly, there was plenty enough space to be alive today. It was just the lack of that seatbelt use that resulted in their death. So I think I'm preaching to the choir here, but as you're out and about, maybe doing some education on adults, those are some resources for you guys to use. You can't really see, but there's the faintest seatbelt sign right here. A little bit of bruising across the belly. Sometimes they get it across the chest. But when you see that, especially in our kiddos, because they have such weak little belly muscles, you're considering they have a surgical injury until proven otherwise. Has anyone heard of Waddell's triad? Some people have, some people haven't. So many years ago, Mr. Waddell, I'm not sure who he is, coined this triad, and it has to do with kids getting hit by cars. Their size makes their injuries much different. So in adults, we usually end up on the hood of the car. Sometimes we bounce off, depends on how hard we got hit. These little guys, their ball rolls across the street, they see mom or dad over there, they dart out in the middle of the road without paying attention. Their first point of impact is generally their lower legs. So depending on how big or tall they are, they'll end up with a femur fracture, a tib-fib fracture, something going on down there. The second point of impact is usually their belly and or their chest, again, depending on how big they are, how big the car is. They get hit in the leg, then they get up on the hood of the car and have that second impact right there. Once they get hit, they then become propelled, and again, the lawn dart effect, they land on their head. So Waddell's essentially said that when you have a kid versus auto, you're looking for lower extremity injuries, chest, abdomen, and head. Those are your biggest concerns. It was a man. I think he was a man. I don't remember. I gotta look into that. But as you're going out and you have this called peds versus auto, you can be preparing yourself for those 3 injuries. I know usually the first thing that runs through our mind is, okay, multi-system trauma. This could be anything from a bump to multi-system injuries, but it kind of gets you to narrow in on those 3 specific locations. Falling objects are a big thing in the pediatric world when we talk about injuries, and they're usual household items. They're not anything big or major. So when you have falling objects, depending on the who, the what, how high, how big your kid is, you are at risk for head, neck, abdomen, chest, and multi-system injuries. And so knowing the details of what fell on the kid, did they self-extricate? Were they awake? Did mom find them? How long were they pinned? All those are factors on how dangerous this is going to be. And I've seen dressers fall on kids, huge gates, like metal gates that are leaning up the side of a barn or a shed, refrigerators fall on children before. Yep, absolutely. Happens more often than you think. It's just not something you think about. You don't think about that bookcase coming down on your child because really we don't talk about it that often, but it can be a very significant injury. Child abuse or non-accidental trauma is probably one of the most unfortunate parts of our jobs, and probably the hardest one for any of us to kind of wrap our brain around, someone injuring their child on purpose. So abuse doesn't necessarily have to be physical. It can be neglect. When we talk about the increased rise in drug use in our community, we're seeing an increase in the amount of kids who are essentially being neglected by their parents. So again, driving home the importance of when you walk into that house, looking at your surroundings, looking for anything that might endanger a child. One of the things that was recently brought to my attention that I never really thought about was, other drugs, is there paraphernalia around, but even more so, is there a dog crate? There's no dogs inside. Are there, things that a parent could use to essentially restrain their child that doesn't match a story? So what I have here are a couple of pictures for you guys that we'll go over, and I just want to talk about, is this abuse, is this not abuse? Has everyone seen this before? Yeah. So it's called cupping. And it's a cultural belief, and actually it's becoming more and more prevalent in the sports community. Like Michael Phelps uses it for muscle relief or muscle regeneration. So it's the idea that you create vacuum, you bring blood up to the skin, and you release toxins and other such things. This one? It's hard to see from this far back. What is it? It's in a specific pattern. So it's actually, if you look closer, it's striated down this way. This is called coining. It's in the same family as cupping. What will happen is you heat up a coin, usually a big one, and you rub it on the skin until you get the ecchymosis. And it's the same thought process that it brings the blood supply to the skin, it promotes the excretion of toxins, and it's healthful. Again, you're not supposed to be leaving marks on your child, but this is a cultural belief that they really do think they're helping. Yeah, right? Oh, darn it, you can't see it. This little guy has both his hands are burnt up to his wrists, the entire hands. And so that's what we call an immersion burn or immersion injury. Usually they'll have demarcation, like there's a very clear line of where the burn stops. They may have it on their hands, they may have it on their feet, they may have it on their bottom. When they have it on their bottom, generally it's kind of like a donut. The middle of their butt is fine, because what happens is when parents do this, they take their babies and they kind of fold them up and they stick their butt in scalding water. Their bottom hits the bottom of the tub and doesn't burn. It's just circumferential. So another really important reason why, if you have the chance, get your babies undressed and really look at them. Because maybe you got the call that he's not been acting right, and you undress him and find signs of abuse, and you realize this is a trauma. This isn't just a regular medical code. This one? I know, sorry guys, these pictures are very difficult. Yeah, so in real life, it's exactly that. It's a hand mark. This kiddo got slapped. And if you look carefully, he's also got some bruising kind of on his ear. Again, it doesn't show up very well. Has anyone ever bruised their ear? Wrestlers aside, it's really hard to do. If you have a kiddo that has bruising on their ear, that should be very, very suspicious. Now, if you see this, how are you going to document it? Right? What it appears to be. So, linear markings, bruising, multiple stages of healing if that's the case. But you never want to say, looks like a hand mark, or looks like, appears to be, because what will happen is that can actually get a case thrown out because your evidence is now tainted with bias and you are not a forensic examiner. So really being careful to only describe what you see. Oh, darn it, this is a really good one. So this little person has these like perfectly circular marks on his hand that are healing. They're cigarette burns. Very common, yep. They're pretty specific. Again, that demarcated edge. The difference between a cigarette burn and maybe a scalding burn is a scalding burn you'll have kind of like a dripping effect almost from where the hot water kind of splashed. This one? Over here? Yeah, that's a whipping. And if you look closely, he's got maybe like a little circular mark there, probably like an extension cord of sorts. But you just describe this as multiple welts, multiple bruising marks across the back as best you can. Do you guys take photo documentation? Some services do, some don't. So, okay. And then this one, I just threw it in here because it's an interesting case. This is actually a chemical reaction. It looks like a hand, right? This is a chemical reaction that has to do with a certain chemical in lime juice and exposure to the sun. If you get this chemical on your skin and go out in the sun, it actually creates a bruising-like appearance. And if you have this juice on your hands and you touch your kid, grab them or do anything to it, and they run outside, it looks exactly like a handprint. And back home in San Diego, we saw this all the time because people barbecued outside a lot, used from lime juice, yeah. And the name always escapes me as soon as I get up here in the front. But, it's like phytophotodermatitis or something like that. It's very interesting. But it mistakenly is mistaken as such. So again, with non-accidental traumas, you want to make sure to document all your findings, all the stories that you hear, because hopefully we get the same story from everyone. You want to be objective and you want to use quotations as much as possible. Sometimes this objective part can be a little bit difficult, and I'll share a story with you guys. When we come up on this, it's very easy to kind of pass judgment and almost assume that you know what's going on, right? We see what's in front of us. It's hard to deny what actually happens sometimes. But one time we had this grandpa bring in his little 4 to 4-year-old. She's totally unresponsive. He said, I don't know what happened. We were just playing and she fell and now she's unresponsive. And as she's got bruising to her head, some bruising on her body, and all of us were like, sure, that's what happened, Grandpa, kind of passing judgment early. Well, as the story went on, she was a victim of child abuse, but her injury was a bleed that she had sustained about a week prior with her dad. She was, in fact, playing with Grandpa. She did, in fact, fall off the bed, and the bleed started over again. So the story totally lined up with pointing at Grandpa, but then eventually we found out the rest and figured out who the real perpetrator was. So just recognizing that sometimes even though it looks perfectly clear in front of you, we don't always have all the pieces to know what happens. And so trying to hold that judgment aside, which again can be very difficult. I get this question asked pretty frequently about who should report, and my answer is everyone. We are all mandated reporters. I'm sure you guys have a method by which you report suspicious activity to DCS. Every once in a while, you think we did it, we think you did it, as far as reporting. And at the very end of the day, no one actually calls DCS, and that child now goes unreported. So I say, if you see something suspicious, file a report, because DCS would rather get 5 reports on the same kid than not to get one at all. Usually our kids who have a fatal or death injury secondary to child abuse have been seen by providers at least a few times in the recent history preceding the event. For example, I had this one little baby, came in, he was improperly restrained in his car seat. Car seat was improperly restrained in the car in the front seat. They got in a car accident, he came in. Thank goodness he was okay, but none of us really clued into those social cues. We kind of just, did a little car seat education, let them go. Same little dude, same caregiver, came in a week later, and he had been completely exposed to methamphetamines. They were selling drugs out of the house, cooking out of the house. If we had maybe filed a report or dug into that social history a little bit more, maybe someone would have gone out to their house and figured out what was going on with this little guy. So don't be afraid to report your suspicions. It's not your job to figure out exactly what's happening. It's just your job to alert somebody that something is not right. Any questions about it? Okay. So penetrating trauma, again, we don't see a lot of it. And really the mechanism is the same. You want to stop the bleeding, replace fluid, get them to a definitive. So when we talk about penetrating trauma, gunshot wounds, stabbing, but also impalement. So falling on a thing of rebar sticking out of the ground, falling on a branch through the eyeball, a pencil. Whenever you have an impalement, we all know you want to leave that object in place if you can when you transport. You go ahead and stabilize it and move it. It can be a little bit difficult if you've got an impaled object and like a 2 or 3-year-old and you can't reason with them to hold still or don't touch it. So you're going to have to really rely on your ability to distract them and talk with them and interact with them. Oops. This is another one. I'm sad you can't see it. So this Eiffel Tower in this picture is like sticking in through the orbit, and it's sticking in up until about right there where the base is. But just an important illustration, so you never know how deep a penetrating object has gone. And so because of that, assume it is right next to the most deep, most important structure in that area. And you stabilize it and get them to where they need to go. I think it was like through the orbit. I think it's like through the side of the orbit, but again, it's kind of hard to tell how deep it's going. The other one will give you a little bit more. With slash markings, especially in our pediatric patients, never discount them because they go pretty deep, especially in wall or thin belly, and they can reach deep structures and then they close up over themselves. So when you see those slash markings, again, just always have in the back of your mind that could be worse than it really looks. Drownings, unfortunately, are usually unwitnessed. That's why they're drowning. There's no one there to pull them out. So along with that comes unknown injuries. When you come up on a drowning victim, you always want to consider the possibility of a head injury, need for cervical spine mobilization, depending on your findings. Are they missing teeth? Is it a low pool? Were they diving? Obviously, you want to start your ventilations as soon as possible and be ready for emesis. It's coming up. Their lungs and their bellies are full of water, so just be prepared with a suction. Support their cardiovascular function and get all their wet clothes off, including that diaper. The diaper gets forgotten about quite a bit, but soaks up all that water. It's sitting right there on their femoral arteries, cooling them down. So get all that off, bring them in naked, cover them up. And I always tell families as you're out in the community and you're talking to people, one of the most important things we can drive home for people is if their child goes missing and they can't find them, the most important place to look first is any large body of water nearby, a pool, a lake, a pond. Go out there, make sure they're not there, and then search your house. Because time is tissue. And most often than not, people will look around the house for their kiddo and then go outside and find them face down in the pool. Burns. Of course, the first thing you want to do is stop the burn. After that, you're looking at ABC. Singed facial hair, changes in voice, all that soot around the nose is going to be indicative of maybe needing an RSI, or you're going to lose your airway soon. Just be prepared for that. Especially in kids, remember a little bit of swelling goes a long way, and it doesn't take much to occlude their airway. Really making sure you're maintaining the warmth. When they lose their skin, they lose their ability to maintain temperature. Even more, so you got to keep them warm. You may or may not douse them with water to stop the burn, the chemical, whatever it is. You need to make sure to dry them off completely and get all that wet stuff away from them. And then start fluid replacement. Recognizing body surface area, I feel like the Rule 9 gets a little bit, trying to remember the difference between peds and adults. So the Palmar method for kids is usually the easiest. Look at the palm of the kid from the base of the fingers to the wrist. That is about 1%, and then you can kind of guesstimate about how much body surface area. Shock, compensated and decompensated. Mostly when we're talking about trauma, we're talking about hypovolemic shock. So compensated, it means that their blood pressure is still good, still within normal. Decompensated is when they start losing their blood pressure. Remember, hypotension is a late sign. So decompensated shock is a very brief stopover to cardiac arrest in kids. They'll compensate, they'll compensate, they'll compensate. They don't compensate for a brief period of time, and then they're done. Right? But prior to that, when they're compensating, they're telling you with their heart rate, they're tachycardic, they're letting you know, hey guys, I'm sick, I need help. So tachycardia, tachypneic will be the first things you see, followed by the obvious prolonged cap refill, altered mental status, and all the other things that we look for. You want to make sure to get fluid replacement going, 20 mLs per kilogram. Everything that we're taught in the hospital says that we can give up to 60 mLs per kilogram before you absolutely have to give blood, before you start diluting them out. So what's your protocol for fluid replacement? Do you do 10 at a time or 20 at a time? 20, okay. Some services are 10 and then 10 and then 10 and reassess in between. So give them 20, reassess. If you made them better, then you can just go TKO. If they got a little bit better but not 100%, maybe consider calling in for a second round. So again, part of our job is to save you when you get injured, but as a community member and as an important part of the infrastructure in our community, our job is prevention too. So talking with people, talking to school-age kids, talking to our friends and family about these things and how to prevent it. How important is helmet safety, water safety, safety in the home, and really having those conversations that hopefully prevent the injury from happening. Any questions? All right. Let's take another break because that's a lot of talking. Sound good? All right.